So we'll start with definitions, pathophysiology, global burden of disease. I've kind of tried to take a public health kind of macro view of a lot of this, rather than kind of an inpatient management focus, but I'm happy to talk about anything. Objectives will define malnutrition, will identify factors and influencing nutritional status, appreciate the global prevalence of undernutrition, understand how measurements are done, discuss the consequences of malnutrition and interventions, more from a public health perspective. So to start, what is malnutrition? Mal means bad, nutrition, and it's been defined by the World Food Program as a state in which the physical function of an individual is impaired to the point where he or she can no longer maintain adequate bodily performance process such as growth, pregnancy, lactation, work, and response to disease. Are you all still there? I'm not seeing anyone. I'll keep talking in case you can hear me, and this is being recorded. The three principal constituents of malnutrition are protein energy malnutrition, deficiency in micronutrients, and overnutrition or obesity. We're really going to focus on malnutrition as an underweight and micronutrient deficiency. We also call this failure to thrive, especially where I practice, and we have two definitions. One is static, which is weight or weight for length, z-score of less than -2 or 2.3rd percentile, depending on kind of whether you tend to use z-scores or percentiles, which we'll talk about, and dynamic. So even if a patient has not yet crossed that line, if they're crossing percentiles downwards, more than 2 major percentile lines, so like if they go from 50th to 25th to 10th, even though they're still at 10th percentile, which would be, you know, z-score around -1, we worry because we don't want to let them get to that kind of worst state after they've achieved a stable growth pattern. So we see this most, although we see it across the lifespan in early childhood, and we see stunting, which is really a focus on low height for age. We're going to go over this multiple times because I think this is kind of the important takeaway. But if it's too elementary for you guys, please let me know. So this is due to chronic malnutrition, and it's chronic restriction of vertical growth indicated by low height for age. Wasting is acute weight loss, and looking at weight for height. So that's where you get, so stunting is short, wasting is skinny, and usually it's caused by insufficient diets, along with infectious disease that can make things worse. In terms of global burden, looking worldwide, these 34 countries in green are thought to account for about 90% of the global burden of malnutrition. However, as you know, we're seeing a lot of what we call nutrition transition, where we're seeing a lot of kind of overlap of underweight and obesity. And we certainly see both in the US as well, with more obesity, but it's still undernutrition in other ways. So malnutrition is really recognized to overlap with the other recognized killers of children under 5. And it puts children with all these other conditions at much increased risk for death. So acute respiratory infections, diarrhea, malaria, measles, HIV, perinatal deaths is the greatest share, and some other causes as well. And we see almost 10 million children under 5 dying each year due to this. And it's the #1 cause of attributable daily. So daily, as you know, is disability adjusted life years lost, versus mortality, where you see more kind of adult diseases of obesity, although child underweight is still in the top 10. So we're seeing a lot of disability as well as death and quality of life issues due to childhood malnutrition. So what are the global trends? The prevalence of stunting is decreasing, but it's still not as fast as as global health experts would like to see. We see overweight rising pretty dramatically. And we see wasting as of 2014 the prevalence was about 7.5%. So 1 out of every 13 children worldwide is wasted, so acutely malnourished. So as you can see, there's a lot of work to do in each area. The Lancet had a great series published in 2008 and then updated in 2013, focused on the first 1,000 days, so from conception to the second birthday, as a really critical time to focus on malnutrition for kind of lifelong health. So the first 1,000 days are, you have to look at fetal growth, cognition, subsequent effect on stunting, obesity, and diabetes in adulthood. And it's really difficult, and the reason that there's this focus on the first 1,000 days is because after 2, it's really hard to reverse these things. Stunting becomes irreversible for the most part. And for every decrement in height for age Z-score at age 2, you see about a loss of about 3.2 centimeters in adult stature. So that's pretty significant. And it correlates with other things like educational achievement, which will affect families kind of lifelong. And then when we talk about nutritional status, that's a pretty broad term. So we can break it down by Daly's disability adjusted life years under 5 into poor growth, as well as suboptimal breastfeeding, and then micronutrient deficiency, especially vitamin A and zinc. So together, these risk factors are responsible for 35% of under 5 deaths and 11% of total disease burden globally. Underlying causes, if you guys are doing pediatrics and adult, I'm sure you're aware of this, but we see kind of the basic causes from a public health perspective as infrastructure, politics, resources, how these resources are distributed, and then access to healthcare and environment, social and care environment, household food insecurity at kind of a more micro level. And then you get down to what is food intake like and what are the infectious factors that make children able to utilize the food that they are taking in. And these all contribute to nutritional status or malnutrition. And it becomes a vicious cycle. So you have kind of pathogens, enteric infection on the micro level. This causes intestinal damage, inflammation, malabsorption and loss of nutrients. And then, you get malnourished from that, and it's very hard to respond. You get changes in microflora, you get exacerbations, and it's a vicious cycle of kind of weakening immunity and weakening and changes as a gastroenterologist in the GI tract. So you can see these healthy normal villi. Here they look like fingers, and then you can see damaged villi flattening, lots of lymphocytes and immune cells. So even if you do get food at that point, it's harder to recover. And we'll talk about how that leads to kind of public health effects. So this is, Dr. Saeed unfortunately was not able to give this lecture. She's a friend of mine, and she does great work. And this is an article she's published on environmental enteric infection. And this kind of shows, again, the normal healthy villi and kind of a range of response when you get chronic inflammation. And you see the infiltration by plasma cells and lymphocytes and kind of this flattening. It's not that different from celiac disease, which we see a lot here. I'm not sure how much you're seeing there. But it is reversible, and you can go in either direction depending on disease and nutritional support and hygiene and things like that. So that's the end of this first section. Any quick questions before I move on?